Top Med Talk.
Nick Majerison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
So our first speaker today is Professor Toby Richards. He is an academic professor of surgery, and he was, until 10 days ago, at the University College London, and he's just moved to University of Western Australia. He's a practicing vascular surgeon. He's a strong interest in clinical trials and patient blood management, and I'd like you to put your hands together to welcome him to the lectern.
Great. Many thanks, and thank you for having me. So I arrived 10 days ago, slightly overshadowed by Harry and Meghan arriving on the same day. So anyway, here I am in Western Australia. And the talk I'm going to give today is essentially directed at how will you manage the patient with preoperative anemia if they present to you in clinic or on the day of surgery. My disclosures, I'm happy to take money off everyone. So what is the issue in surgery? We're increasingly doing local anaesthetic. We think we're very good as surgeons, and we increasingly do minimally invasive surgery. And my aim is to keep my anaesthetists in the manner to which they've become accustomed. The reality is that we're operating on older and sicker people, and we've heard some excellent talks about that and how to risk stratify and if we should be doing these operations. But nevertheless, we are. And transfusion is real. The Ubers in Australia don't seem to be the same quality as I'm used to in London, but a short 2-minute film.
Morning, gentlemen.
Good morning, sir.
Not late, I hope?
Not at all, sir.
Come along, my man. You must pursue me. I suppose you got another half-dozen boring cholecystectomies today?
Yes, sir.
After last night, I feel like one myself. How about that gastrectomy I did yesterday?
Not so well, sir.
Oh, pity. Great pity. Morning, sister.
Good morning, Sir Lancelot.
Everything ready?
All ready, sir.
Splendid. Now, you just lie still, old fellow. I've just got to discuss your case with these young doctors here. Take his pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked?
Yes, sir.
See anything?
No, sir.
Very good, carry on. Gently, man, gently, you're not making bread. Don't forget to be a successful surgeon. You need the eye of a hawk, the heart of a lion, and the hands of a lady. Found it?
Yes, sir.
Well, what is it?
A lump.
Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, don't worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man. Cut it out. And where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. Now, don't worry. This has nothing whatever to do with you. Now, you. When we've cut through the skin, what's the first substance we shall find?
Subcutaneous fat, sir.
Quite right. And then we come across the surgeon's worst enemy, which is what? Speak up, man! Blood, you numbskull! You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time?
10 sir.
Amazing how true that. 1958, so 60 years ago. The enemy of the surgeon is blood. So where do we start with preoperative anemia? When we start, as has been pointed out, with good quality audits, and this is the National Quality Improvement Program, in America through the VA hospitals, and you'll have heard of this database. The important thing about this database is the name. It's a quality improvement program, and we analyzed to see whether or not preoperative anemia, controlling for a variety of variables, has an impact on outcome. And we took this rather messy-looking univariate analysis and turned it into this diagram where you have decreasing hemoglobin along the bottom. And what you can see is that the mortality increases in a linear fashion as your hemoglobin falls from 13 down to 10 and beyond. And similarly, the morbidity increases in a linear fashion. So there's definitely an association between preoperative anemia and outcome. And the important message from this slide is it's independent of sex. So if you're a female and you've got a hemoglobin of 13, the same as a man, then your risk is the same. But if you accept a lower hemoglobin for women at 12, then they have a 40% higher risk association before you even start the operation. So should we be treating women better than we treat men and not accepting lower levels for them? And is transfusion the appropriate way forwards? There's no doubt that transfusion is the appropriate treatment of blood loss, but is it the appropriate treatment for anemia? That is, after all, a stable patient. And there's a variety of data showing association between transfusion and adverse outcomes. And these risks appear to be independent of baseline variables here in propensity matching, or whether or not they're undergoing a hysterectomy, spinal surgery, or orthopedics. The risks are very much the same. This database is in 1.6 million. There's another database by Vic Ferraris in just under 1 million, all saying much the same thing. And the story actually starts here in Australia. It starts in Western Australia, where I am now here, surrounded by, I think it's crocodiles up here and sharks down here. And the problem is there are 3 main hospitals with 14 base hospitals, and the transfusion service will be stretched if there's a major car accident or a major hemorrhage. And the then chief medical officer back in 2008 wanted to address our love affair with blood and the fact that we used blood in an ever-increasing manner. He introduced this thing called patient blood management, which was coined by James Isbister here in Melbourne in 2007, and developed the background literature review and a series of audits. It was implemented in response to demand. He showed a rise in the rate of transfusion utilization. And looking at DRG coding, they showed that those people with anemia cost the government and the healthcare system more money. You've heard about implementation strategies and quality improvement programs, and this is what it was. They identified the drivers for change, and they implemented a program of patient blood management, which is about correcting and increasing the red cell mass, i.e. anemia, prevention of blood loss, and tolerance or restricted transfusion. And this nicely in surgery falls into the pre-op, the intra-op, and the post-operative setting. It was implemented through a variety of audit, re-audit, and patient and educational change. And over the 5 years, where they spent $14 million doing this, you saw a decline in product utilization in all areas of medicine across the state, and WA has the lowest transfusion utilization of any Western country in the world, with an annual cost savings compared to 2008 of $24 million per year. So it was a program that has worked well. So we've copied it. We copied it in the United Kingdom, and then throughout Europe, and more recently the Americans have adopted it. And if you read the literature now, you would think that they invented it themselves. So how do we manage preoperative anemia before here the orthopedic surgeon gets to you? Well, I'm going to go back to data to take you through a benchmarking audit, because the theme of this conference has been about data and collecting your own data and audit. And I firmly believe, as a research scientist, that audit is a fantastic way forwards, and it's far better than bad quality research. This is a project we did a couple of years ago in the UK, and whereby we had transfusion nurses who pulled the notes from patients undergoing 16 different types of major surgery, revision hip, aortic aneurysms, colectomies, cystectomies, the like. The audit standard was the NICE guidance in 2015, and I can summarize that by saying consider alternatives to transfusion before you give blood. We divided it into a series of algorithms, 11 different algorithms divided into pre-op, intraoperative, and the post-operative phase. And I won't go through these, but essentially they were clinical practice algorithms. So for preoperative anemia, do you actually do a blood test? Do you actually look at the blood test? That's always the next question. If they're anemic, do you do the hematinics? And if you find that they're iron deficient, B12 or folate, do you do anything about it? So these were clinical management algorithms. We looked at just under 4,000 people, and the data here is removing the fractured neck of femurs. So it's 3,000 people. We'd picked the right group of patients because they used over 6,000 units of blood, so about 2 units each. And the average blood loss was about 1 litre per patient. And the average transfusion was at a hemoglobin of 83. So what I'm going to go through is the results, and I'm going to compare those people who met the algorithm standard, i.e. you did do what we suggested, compared to those who did not. And the end point will be how long did the patient stay in hospital. So if you're compliant with current guidelines, does it make a difference to the patient? Looking at preoperative anemia, and I'm going to be slightly vague on this because I run one of the trials and we just closed and I'm not going to tell you the results at the moment. We know that preoperative anemia is associated with the need for more blood, and we know that preoperative anemia is associated with a higher risk of dying. Again, associative data, it's not causal. There's something very wrong with this slide, and I'm going to explain that in the next few slides. But we instantly think on preoperative anemia now, they're anemic, let's give them a bag of iron. Is that the correct thing to do? Well, the underlying distribution of iron deficiency as causality for anemia is rife. It's about 3/4. This is data from the Gates Foundation. I keep pressing the wrong button, sorry. This is data from the Gates Foundation showing the cause of anemia, here green, in different countries around the world, and the incidence of anemia, which is around about 15 to 20% in the Western world, and the majority of the population in sub-Saharan Africa. Other causalities include GI loss, women's health, as I've mentioned, the importance to look after women, and also thalassemia, etc. So iron deficiency is probably around about 75% of all causal factors. And the important thing about iron deficiency is that anemia is the end stage. Anemia is that you have so little iron in your body, your bone marrow is failing. It's the same, as far as I'm concerned, as having so few nephrons that your eGFR is below 30. So I regard anemia as an end organ failure. You have about 4,000 milligrams of iron in your body. 1,000 milligrams is held in reserve, and that's stored predominantly in your macrophages and in the liver as ferritin, and that's your store. As you become iron deficient, you slowly lose that store of iron, but then you start sequestering the iron from other areas in the body. And iron is important not just to make a red cell, but it's very important in the mitochondria because it's what converts oxygen and glucose to ATP. Your free radical biochemistry, your electron transfer chain, etc., etc. That's all mediated by iron and other transition metals. And it's vitally important for neurocognitive function as well. And that's why, if you talk to women, and behind all the research, we've done a lot of work on social media, and you actually ask women what the symptoms of iron deficiency are, they're not just fatigue and tiredness. It's actually, wrong button, it's actually shortness of breath. Hair loss, because ferritin's incredibly rich in the skin, and your hair follicles need a ferritin above 300 in the skin to maintain growth. And hair loss is a very common symptom in the postpartum. Headaches, brain fog, not feeling unable to think clearly. Mummy brain is another one. Eating ice. If you've got a ferritin of less than 8, it's highly likely you might have a condition called pica. There's a strange desire to eat soil in the textbooks, but actually if you ask patients, it's this desire to eat ice. They get literally buckets of ice and sit there crunching through it. Tissue paper and restless legs are well known, particularly in the elderly population. And these are all related to iron deficiency, but not anemia. And when you look at iron deficiency, this is the absorption pathway. This is the enterocyte, and the bowel lumen is on this side. So you've got food coming in here. And to the vegetarians, I'm afraid there is a predefined meat absorption pathway through HCP1, so we're obligate carnivores. And meat is preferentially absorbed into the cell. If plant iron is really badly absorbed, about 10-fold less absorption, it requires a very acidic stomach of a pH less than 1.8. So if you're on a metrazole, you can't absorb iron very well. You need vitamin C, and the iron is absorbed through divalent metal transporter 1. This is only found in the duodenum. And so if you have gastric bypass surgery, you can't absorb iron. And about 3 years later, because you have stores of iron, bypass patients can often come profoundly iron deficient. Iron is then actively transported out of the cell. So getting into the cell is hard enough. Getting out of the cell is even harder. And then it's moved around the body by transferrin and essentially stored as ferritin. So iron can get into the cell, but it can't get out. And the control mechanism is the getting out of a cell, so it can be transported around the body. So Popeye was wrong, because essentially this is plant iron, and you need an awful lot of spinach. Here, 1 kilo of spinach, and this is better for you. And it makes matters worse when a patient comes into hospital, because that patient is unwell and they have inflammation. And inflammation, general badness up here, activates the regulatory protein hepcidin in the liver, and that shuts down that transport mechanism out of the cell. So what happens is it doesn't matter how much meat or, if you really want to, spinach, give the patient, they can't absorb it from the gut. It can get into the cell, but it can't get out the enterocyte. Your macrophages are trundling around your body, and they will take up all the iron that's knocking around, but it can't get out. So your ferritin level artificially goes high, and a ferritin on someone on intensive care will be about 1,000. And that's because there is no ferritin available to be delivered, no iron available to be delivered to the bone marrow, and that leads to bone marrow failure, which leads to anemia, and that is functional iron deficiency, or what we used to call anemia of chronic disease. And does oral iron work in this setting? Well, no. There are actually 7 randomized controlled trials showing no benefit whatsoever in the post-operative period for oral iron. So if you remember nothing more, please stop prescribing oral iron in hospitals. It's an utter and complete waste of time and just gives patients bellyache. Does intravenous iron work? Well, yes. In all the randomized controlled trials here in the Cochrane review, intravenous iron is far more effective to correct baseline iron deficiency and correct anemia. So in the setting of the surgical patient, should we be using intravenous iron? Well, data from Bernd Frosler, based down in Adelaide, suggests that we should, in this actually quite small study of 72 patients. And he showed that the use of intravenous iron reduced the need for blood transfusion and improved discharge rates from hospital. However, the other trial on 112 patients in colorectal surgery showed no benefit at all. And actually, in the preoperative setting, oddly, there was still a role for oral iron as long as you gave it to patients for several weeks before they had their operation. So we, hopefully, by this time next year, will be reporting on this trial, which is randomizing 500 patients to intravenous iron or placebo with patient-related endpoints. And until then, hang on with the oral iron and the IV iron, and we'll give you the answers next year. So what are you going to do with your preoperative anemic patient? Well, the other areas of patient blood management are to avoid bleeding. Yet 18% of our patients coming in for major surgery are either on dual antiplatelets or they're on anticoagulants. And the next speaker will talk about anticoagulants, so I'm going to talk about antiplatelets. Everyone's on antiplatelets. How many in this audience routinely stop all antiplatelets prior to major surgery? I would suspect not that many. But there's no evidence that we should continue. In the POISE-2 study, they randomized 10,010 patients to stop their aspirin if they were on it for 3 days prior to surgery, or if they were not on it, they were put on aspirin. So they randomized people to aspirin or no aspirin during the course of their operation. The primary endpoint was death and myocardial infarction, and there was no difference whatsoever. So there was no benefit from staying on aspirin. But the risk of major hemorrhage, defined as 2 or more units of blood or a complication of hypovolemia, was dramatically increased if you left people on aspirin. This is also confirmed in the Atticus study looking in cardiothoracic surgery, where patients were randomized to aspirin or aspirin cessation prior to cardiac surgery, and you'd think this would be the highest risk group. And again, there was absolutely no signal whatsoever of any benefit in any of the predefined domains for benefit of being on aspirin. So stopping aspirin, whether in non-cardiac or cardiac surgery, is entirely acceptable. It has no detrimental effect to the patient, but it does reduce bleeding. And interestingly, it reduces bleeding not just on the day of surgery, but for up to a week after the operation as well. And if you stop antiplatelets and you stop anticoagulants in an appropriate manner in the setting of our audit, looking at 3,000 patients, those people who were stopped and according to protocol, at least 3 to 5 days prior to surgery, had a significant reduction in their length of stay in hospital. But what about those people who turn up on the day? Well, don't underestimate the quality of cell salvage. The thing about cell salvage is, first of all, you've got to find the machine, and then you've got to find the person who knows how to put the machine together. But you've all got one. There's virtually one in every department of the hospital. If you haven't got one, just phone up the Jehovah's Witness organisation and they'll buy you one. They will. There's actually a shed load of data. There's over 70 clinical trials that if you utilise cell salvage, you reduce the need for someone else's blood. And after all, I'd much prefer to have my own blood than someone else's during major surgery. And if you're not sure, if the surgeon goes, I never lose any blood, and you know he's lying, well, what you can do here is, this is swab washing. So this is an open aortic aneurysm operation, which we pretty much don't do anymore, so consequently I don't get to do them because the registrars want to do them. To keep the registrars occupied, you get them to wash the swabs. So this is a litre of normal saline with 5,000 units of heparin. And you wash the swabs as you go, so nurses love it because they don't need to get so many swabs out. The registrars are very happy because they've got something to do. And at the end of the operation, you can just reinfuse the blood when you, knowing better than the surgeon, realise that they did actually lose about a litre of blood. Costs nothing, keeps everyone occupied, very cheap and easy. And so try it. And actually, if you're worried about cancer surgery, I'm not too worried about cancer surgery and the use of cell salvage. There's a cracking editorial from the Canadian journal essentially showing that if you look at the 9 clinical trials on the use of cell salvage in cancer surgery, there doesn't appear to be any increased risk of metastatic cancer developing at all. And the accepted standard of practice is to reinfuse with a leukocyte depletion filter. There's always risk in surgery. But one thing I can tell you is if you give an allogenic blood transfusion, someone else's blood, there is definitely an associated increased risk of cancer recurrence out to 5 years in most GI cancers. So I'd prefer to have my own blood. Thank you very much. And if you use intraoperative cell salvage in those people who do require transfusion, it's again associated with a reduction in length of stay. Other aspects are breaking down taboos. You've heard about that in change programs. Everyone thinks tranexamic acid causes clots. Tranexamic acid cannot cause a clot. It's biologically not possible to cause a clot. tranexamic acid stops clots from being broken down. So it binds plasminogen, which prevents TPA from binding into the clot and breaking the clot down. My main operation is carotid endarterectomy. I use tranexamic acid on every single case. We've done TCD studies. There's no increased instance of microembolism. And essentially, in the UK, we regard the use of tranexamic acid as mandatory in all areas of surgery. If you look at the data, there's a very nice review from Ian Roberts' group looking at all areas of surgery, and essentially it reduces bleeding by about 30 to 40% in most areas, and you have all heard of the CRASH trials. And more recently, the woman trial, looking at postpartum hemorrhage. If you use tranexamic acid, it stops women from dying in childbirth. It's cheap, it's simple, and it works really well. The Atticus trial, again, looked at the use of tranexamic acid in cardiothoracic surgery. So, again, the cardiac surgeons very worried about causing clots and their grafts going down. The use of tranexamic acid almost halved the need for blood transfusion, reduced readmission rates to surgery, and had no detrimental effects whatsoever. If you forget to give it 1,000 milligrams at induction, you can also here spray it onto the wound. This is really good in breast surgery. So what you do is when the wound's fully open, this is a popliteal artery aneurysm bypass, and you can see I don't lose any blood at all. This is me spraying tranexamic acid on the wound. In breast surgery, when you've done the exposure, particularly in breast reductions, you coat the wound with tranexamic acid. It avoids the need for drains, and it reduces postoperative seromas. It's quite a neat trick. The other one's point-of-care testing. So if you do have bleeding, this is a very good argument to ensure that your department gets a TEG machine or a Rotem. In this study, the group from Kaiser Karowski randomized people undergoing complex cardiothoracic surgery to the use of point-of-care testing or traditional laboratory sampling. What they showed is if you use point-of-care testing, this increased the speed of appropriate management and intervention by products or cryoprecipitate, etc. It reduced overall cost and actually reduced mortality out to 45 days. The most important thing for point-of-care testing is to take a photograph of this slide so you know what these images mean when they come out of the machine. Very similar to the cell salvage, you must be familiar with the machines to know how to use them. But actually, I've stolen this off Beverly Hunt. It's very useful to have that as an aid memoir on the side of theatre when the panic is going on major hemorrhage. And if you utilise these adjuncts in theatre, again, you reduce the need for blood transfusion and you reduce length of stay in hospital. So there's a variety of things to manage preoperative anemia, and it's not about treatment of the number, it's about the package of the patient blood management care. And so looking here at the distribution of blood transfusion around the time of surgery, preoperatively, it's about identifying those people with anemia. Have they got iron deficiency, B12 or folate, or another reason? If it's elective surgery, is it absolute iron deficiency? Is it a new thing, in which case they might need to go off and be scoped? But if they're iron deficient, treating the iron deficiency as appropriate. In the operative setting, if you think you're going to lose blood, find out where the cell salvage machine is. Always use tranexamic acid. And post-operatively, I haven't spoken about it, but it's restricted transfusion. So that's the facts. And it's been shown in Western Australia how to do it. But actually, how do you, on the ground, right now, go and change practice? So when you go back to your department, what do you do? Because here's the ward round, here's the surgeon. I'm going to promote him to be a surgeon. And they want to get on with the operation. So we did a little study, and I found a medical student, Devisha was her name. She was very keen. Lovely smile. And we undertook an educational program, and we taught her. We took her to a series of lecturers. We got myself and an anaesthetist together, and we implemented a protocol. And we did a series of audits, speaking to the pharmacists, speaking to the nurses, the theatre staff, about collecting swab wash and so on and so forth, and went round and gauged everyone's opinion. And then, like a good supervisor, I stepped back and let Devisha do all the work. And this was the protocol. It was devised as a simple tick-boxing exercise, preoperative, intraoperative, and post-op. Now, the intervention here is not that we gave tranexamic acid or that we used cell salvage. The intervention was that we had a tick-box exercise. So we got people thinking, and the intervention was Devisha going on the ward round and walking around the hospital and department and going, why? So when you're in theatre, she would sit there and go, why is this person not getting tranexamic acid? If you gave 2 units of blood instead of 1, why are you giving 2 units of blood instead of 1? So it was like being a little 4-year-old asking why. And that gets people thinking. And patient blood management was designed as an educational change program, audit, education and feedback. And by prompting with a series of checklists or that why, that is what the intervention is about. The starting point was a group of patients with critical limb ischemia, so fairly sick, over 2 6-month periods. The second one was 3 months because her degree was over 3 months. And they were the usual plethora of vascular patients, which were pretty sick. But what we showed was a significant reduction in transfusion over the course of her time, approximately halving the transfusion rate. We showed that there was a shift from 2 and 3 and 4 units of blood being given down to 1 and 2 units of blood. And we showed that we were transfusing at a lower hemoglobin level more appropriately. And we also showed a reduction in length of stay in hospital during the course of the time program. So my message from my talk is that patient blood management is in keeping with everything else you've heard in this conference. It's implemented through simple audit and simple benchmarking, as we've seen. This is highly effective. And to be a champion, you don't need to be anything more than someone with a smile on their face who asks the right question at the right time, and you get people around you thinking and engaged in the process. What works? Thinking about anemia, thinking that it's a risk and doing something about it. Stop the anticoagulation and stop the antiplatelet therapy. At operation, give tranexamic acid. Find where the cell salvage machine is. Find the person who knows how to use it, and then use it. And utilize your point-of-care testing. This works. Thank you.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.